So, how are we going to assess a malfunction in bioprosthesis? Here we go. So first of all, again, I already told in the previous talk, there are a lot of different heart valves available at the moment. So there are 25 different brand names, more than 44 models. They have a big range in these valves, so that's something you cannot keep in mind. So there are definitely tables and information you can use, like apps, and I will show you. What do we assess with a normal bioprosthetic valve or just a prosthetic valve? We need to know what is the valve size, what is the valve type, and we have to keep in mind the gradients are also determined by the flow rate. So patients that are anemic or have a high thyroid function, this can also influence the gradients measured by echocardiography. So, and I'm glad there are several tables available now for all the different valves showing the normal values which are we can assess when we do the examination. Also in the app, this is the EchoCalc lab from the British Society of Echocardiography, where we can simply check our valve, put in the measurement of which size we do have, and it will give more or less the EOA and the standard gradients of these valves. But we also have to keep in mind that different valves have a different profile, and of course we're not going to see this in mitral, but these are the most used valves. But in mechanical valves we are going to see a flow pattern that is more or less like this, with a higher flow in between the disc, and this is also something we can sometimes measure and can cause confusion. So just showing the standard valves that are frequently used. So these are sewing rings with semi-rigid stent with studs, and they have porcine aortic tissue or a bovine pericardial tissue. It's a tri-leaflet valve that opens to a circular orifice, and normally these valves have a regurgitated volume about 1 mil, so almost none, but 10% of these valves show some degrees of regurgitation after implantation. So what is important when we do the assessment? So the evaluation is similar to the native valve. So the measures we're going to do are similar to the native valves, but we have to keep in mind these valves can cause reverberations or shadowing that can play a significant role, and especially of course when we have metal prosthesis, this shadowing is a bigger role. Fluid dynamics play an important role and can influence the Doppler findings. So when we start the examination, we need clinical information. Like I already said, we need the date of implantation. We need to know what kind of size, what kind of type we are dealing with, what is the weight, what is the height, and what is the body surface area, what are his symptoms, and we need to know what is his blood pressure and the heart rate. What's also very crucial and we really need to do after implanting a valve, we need to have a post-operative study, which we can compare the study nowadays with, because we simply have a sort of situation. We know it was past procedure and we can compare what the differences are. We should know the normal Doppler patterns. We should take into account the artifacts and the shadowing, and we have to know in which situations, besides thrombosis or stenosis of the valve, we can also get higher prosthesis gradients. So this is a normal flow pattern, a gradient around 4, a shorter pressure half time, a bigger EOA, and with obstructed valve we will see the gradient will go up. Frequently the pressure half time will increase because it's taken longer to get equilibration between the left atrium and the valve, and EOA goes down. So when we do the assessment, we want to have the maximum velocity, we have the mean gradient, and important as an echocardiographer that you mention the heart rate when we measure the gradient, pressure half time, and the EOA. And nowadays these nice flowcharts have been developed when with the measurements you can put in this flowchart and can determine, is it a high flow state, is it really a dysfunction of the valve, or is something else going on. And I like the flowcharts, but one of my former colleagues made this fantastic app. I really like this one because we can check our prosthesis by downloading the CardioValve app. I would also recommend you to download this one because we can simply click on the prosthesis we're going to use. We select it in the list. It will give you the gradients according to the valve size, but also we can work the other way around. We can give the height and the weight of the patient, and it will calculate what kind of orifice opening you need, and it can say this valve or this valve will be probably the best for this patient. And if we put in the valve and we put in the weight and the height of the patient, it can tell you if there is a PPN, yes or no. But also, and I cannot show you on the slides, but you can also put in all the measurements that we just got from our echo study, and it can help you through this flow chart. So you just fill in the measurement and it will tell you according to the flow chart if we are going to have a high flow state or an obstructive valve. And when you're in doubt, we really need to do a TE in these prostheses. So if you have non-diagnostic imaging, if you want to assess if there is a concomitant regurgitation, and when you're in doubt if there is an obstruction and maybe a patient which is a candidate for thrombolysis. This is not bioprosthesis, but again, you really have to know your valve. When we're looking at mechanical valves, you have to know the normal flow pattern. So you can see this is a bi-leaflet valve, which frequently has these 3 regurgitant or washing jets. It's different with a single disc, and of course we don't see this a lot anymore, but this has a completely different appearance on our echo. And again, shadowing and flow masking is crucial, and especially if we're looking at the mitral prosthesis, the prosthesis itself can cause quite a lot of flow masking, and especially for paravalvular leakage and these kind of things, the transthoracic imaging can be really impaired compared to when we do an assessment of the aortic valve. So just to show you, I found one of these cases when we can see the 2D images, and we can see quite some turbulence going on over here, but it's not really clear what is going on. But in this patient, if we move on to the TEE, it's quite clear what is the problem. We can see there is a dehiscence here on the anteroseptal side, and there's a huge paravalvular leakage in this patient. So it's really difficult to see this on just a transthoracic echo, and which can be clues on transthoracic echo for significant mitral valve regurgitation. If there is a high inflow, so a regurgitant volume that comes in, there's a high inflow, and we have a sort of pseudostenosis with a high mean gradient, and we have an elevated flow over the mitral valve compared to the left ventricular outflow tract. We see a good function, but there is a low systemic output when we measure the VTI, and frequently we have pulmonary hypertension. So in this situation, you really should consider doing a TE in this patient and look for paravalvular leakage. And I'll have a lecture later on about paravalvular leakage, but just in short, if you do a TE for this, you do a complete sweep around from 0 to 180 degrees. Keep your probe fixed, because this is really crucial to get an idea how big this paravalvular leakage is. I frequently get referrals from other hospitals where they really love to show the paravalvular leakage, and from 1 to 0 degrees to 180, every time they turn the probe towards the leak. I have no clue how big the leak is. So keep your probe stable and just simply do a sweep from 0 to 180, and use also 3D TE to visualize it. But again, I will get back to that in another lecture. So to show the paravalvular leakage, to show the regurgitation, and with the 3D MPR mode, we can simply get the dimension of the paravalvular leakage. Another problem is structural valve deterioration. Of course, this is a problem with tissue valves, and this is more common in younger patients, patient with an altered calcium metabolism, so patient on dialysis, and it depends on the valve type. So what we can see is thickening, calcification, but we can also see perforation, or, a degeneration of the leaflet, and this can result in regurgitation. Usually it goes gradual, but sometimes it can be acute because of the rupture of some of the leaflets, and it can be massive, but also stenosis can be seen, or a combination of these. And just an example to show you, we can see this is a prosthetic valve where we can nicely see the limited motion of these leaflets. So it's not that pliable and not that flexible anymore compared to the after implantation. And if you look, it's a bigger problem with mitral valves, of course, and we can see the bioprosthesis start to deteriorate after 6 years, having a 50% at around 50 years that has a structural valve deterioration. And again, the younger you are, the bigger the chance you will have structural valve deterioration. It also depends on what kind of valve we're going to implant in these patients. So if you look at line C and D, over here, again, the highest rates are seen of deterioration in the mitral valve, but you see it's much more frequent when we use a porcine valve compared to a pericardial valve. So keep that in mind with implantation. Another problem is the valve thrombosis. The incidence is around 0.3 to 1.3. It frequently the highest rate, although it's a big issue being discussed in TAVI valves after the issues with that, but actually the highest rates are seen on the mitral and the tricuspid size. Of course, in mechanical valves, you can see it in the patient with inadequate anticoagulation, and the clinical findings are frequently heart failure, dyspnea, and these kind of things. It can grow gradually, but also have an acute onset, and you have to determine if you're going to give anticoagulation. In more acute situations, you have to consider thrombolysis or surgery. And I think it is a misconception that the valve thrombosis only occurs in the first 3 months. This is from the Mayo Clinics, having 31 patients that had the valve thrombosis, and what they saw actually in the second year after implantation, they saw the highest incidence of bioprosthesis valve thrombosis, and the longest one even was after 6.5 years. Just to show you an image, frequently you will see thickened leaflets, masses on the leaflets like this, and you know more enough. And a little bit depends on the clinical condition of the patients, how aggressive you're going to be with your therapy. And just to compare it with the degeneration, the thrombosis in these is more a problem on the earlier side, and degeneration is something that takes a little bit longer. So how to get the conclusion on TEE? We can look at if there is an increase of gradient of 50% or more, if there is a thickening of the leaflet cusp, or if there is abnormal motion of the leaflet. You can see if you have all three, we have a sensitivity of 7.2 and a specificity of 90% of having a valve thrombosis. Just to show you an example, before and after treatment, we can see the thickened leaflets over here, completely thickened, and after you're giving thrombolysis in this patient, you can see nice thin leaflets completely mobile again. But a word of caution should be, because not all immobile cusps are thrombolized, so this is after implantation on the OR, and we can see normal movement of these leaflets after implantation, nicely shown also on 3D. But if you go to the 4-day, this is only 4 days post-operative, you still see the leaflets are not thickened, but you can see, goes back, but you can see already something is happening here, so it's not that mobile anymore. And this was a patient that had a lot of mitral valve annulus calcification, and the calcification pushed the stent of the bioprosthesis inside, and that caused deformation of the prosthesis and a malfunction of the prosthesis. So it's not always thrombosed in the early days. And one doesn't exclude the other, because this is a patient that had a bioprosthesis thrombosis in 2014, where you can see the leaflets are thickened, are immobile. It was nicely treated with anticoagulation, but 3 years later, you can see there's more calcification, also thickening, and now the patient has deterioration of the valve, so it had to be replaced. In some of the cases, but it's rare to be seen on bioprosthetic valves, you still can also see punnets, so the thickening as well. It can also be punnets, but it's difficult on echo to make a difficult judgment to make sometimes. And finally, another word of caution, because not all thickened leaflets are thrombosed. This is a patient, unfortunately it doesn't seem to be moving, but also thickened leaflets over here. But this patient also had fever and had a positive blood culture, and this was treated with 6 weeks of antibiotics, completely getting a normal function. So not all thickened leaflets are thrombosed. And sometimes it's an effect as endocarditis. The risk for this is 0.5 a year. It depends on early or late pathogens. Of course, with mechanical valves, frequently you will see it on the sewing ring, and less frequently you can see vegetations on the disc. Tissue valves, you can see it on the disc and on the leaflets, and the complications are large, which you can have, of course. So, important when you do the evaluation, you need to know the date, the type, the size, some patient characteristics, you need to know the symptoms and the clinical findings, and the blood pressure and the heart rate. And important is that you compare it with post-operative study and to see for changes after baseline. And when in doubt, have a low threshold to do a DE in these patients. Thank you very much.